Hello, my name is Jacqueline Nicole Muniz, and I am a DNP student at Palm Beach Atlantic University. Today I will be discussing a case study focusing on esophagitis and esophageal cancer as it pertains to our current study of the gastrointestinal tract. In this case study, the patient is a 51-year-old white man who presented 10 years before surgery with a history of heartburn, regurgitation, and epigastric pain. Endoscopy was performed, and a large erythematous area involving the distal esophagus was noted. Biopsy specimens were taken and showed features of reflux esophagitis. The patient was treated with anti-reflux drugs and given a follow-up appointment in 1 year. The patient returned 3 years later complaining of dysphagia, heartburn, and epigastric pain. Endoscopy was performed again and revealed that the normal white squamous mucosa lining the distal esophagus was replaced by pink columnar mucosa. Biopsy specimens were taken, which subsequently showed metaplastic columnar epithelium containing intestinal goblet cells. Because of the diagnosis of Barrett esophagus, the patient was enrolled in a surveillance program and yearly endoscopic procedures were recommended. Endoscopy showed extensive Barrett esophagus 6 years before surgery, and biopsy specimens showed features of dysplasia. The patient failed to return for subsequent surveillance endoscopy. The patient was admitted with increasing dysphagia 1 month before surgery. An upper GI series revealed distal narrowing of the esophagus. Endoscopic examination of the esophagus revealed an ulcerating mass in the distal esophagus. A biopsy specimen was obtained. The patient was taken to surgery where an esophagogastrectomy was performed. To begin, we must discuss diseases of the gastrointestinal tract that prove precursors in the diagnosis of esophageal adenocarcinoma. Reflux of gastric contents into the lower esophagus is the most frequent cause of esophagitis, which is inflammation of the esophagus. The most common cause of reflux esophagitis is also termed gastroesophageal reflux disease, is transient lower esophageal sphincter relaxation. This is thought to be mediated via vagal pathways and can be triggered by gastric distension, gastro-food, mild pharyngeal stimulation that does not trigger swallowing, and stress. This disease can also occur following swallow-induced lower esophageal sphincter relaxations or due to forceful opening of a relatively hypotensive lower esophageal sphincter by an abrupt increase in intra-abdominal pressure, such as that due to coughing, straining, or bending. Alcohol and tobacco use, obesity, CNS depressants, pregnancy, hiatal hernia, delayed gastric emptying, and increased gastric volume can also lead to GERD. In many cases, no definitive cause is identified. Barrett esophagus is a complication of chronic GERD that is characterized by intestinal metaplasia within the esophageal squamous mucosa. It is estimated to occur in as many as 10% of individuals with symptomatic GERD. Barrett esophagus can be recognized as one of several tongues or patches of red, velvety mucosa extending upward from the gastroesophageal junction. This metaplastic mucosa alternates with residual smooth, pale squamous mucosa and interfaces with light brown columnar mucosa distally. Finally, most esophageal adenocarcinomas arise from Barrett esophagus. This suggests that increased rates of this disease may be due to increased incidence of obesity-related GERD and Barrett esophagus. Other risk factors include tobacco use and exposure of radiation. Molecular studies suggest that the progression of Barrett esophagus to esophageal adenocarcinoma occurs over an extended period through the stepwise acquisition of genetic and epigenetic changes. In a research article by Kalsam, Meidel, and Agrawal, researchers critically reviewed the current status of biomarkers in the GERD, Barrett esophagus, esophageal adenocarcinoma sequence and discussed a potential role of epigenetics in the pathogenesis and progression of the disease process. They also discuss the significance of this knowledge in developing biomarkers that correlate more closely with disease progression. Research uncovered genomic instability could be a critical factor to initiate the metaplasia-dysplasia-neoplasia sequence. Several studies have explored the role of p53, APC, CDKN2A, cyclin D1, and Rh genes. Mutations in these genes have been implicated in the progression of many cancers, including esophageal adenocarcinoma. As far as the genetic makeup of these gastrointestinal diseases, emerging evidence suggests a genetic underlying component to the etiology of esophageal adenocarcinoma and its precursors. In a study by Eck et al., genome-wide association data was used to investigate the genetic architecture underlying GERD, Barrett esophagus, and esophageal adenocarcinoma. Researchers applied a method to estimate the variance explained and the genetic correlation between these three diseases by considering all single nucleotide polymorphisms simultaneously. They also estimated the polygenetic overlap between the three diseases using a prediction approach. The genetic correlation between Barrett esophagus and esophageal adenocarcinoma was found to be high. Data also suggested, together with the high genetic correlation, that shared genes underlie the development of Barrett esophagus and esophageal adenocarcinoma. Conversely, no statistically significant results were obtained for GERD. As for the clinical presentation, common signs and symptoms of GERD include heartburn, dysphagia, and regurgitation of sour-tasting contents. Complications include ulceration, hematemesis, melena, stricture development, and Barrett esophagus as previously discussed. Barrett esophagus presents as GERD symptoms. Complications include esophageal adenocarcinoma. Finally, an individual diagnosed with esophageal adenocarcinoma may present with GERD symptoms, as well as pain or difficulty swallowing, progressive weight loss, hematemesis, chest pain, and vomiting. 5-year survival in advanced stage is less than 25%, and 5-year survival in early stage is approximately 80%. All three of these gastrointestinal diseases are diagnosed following endoscopic procedure. Diagnosis of Barrett esophagus requires endoscopic evidence and biopsy that reveals metaplastic columnar mucosa above the gastroesophageal junction. Intestinal-type metaplasia is seen as replacement of the squamous esophageal epithelium with goblet cells. When dysplasia is present, as is featured in this case study, it is classified as low-grade or high-grade. Once a diagnosis of Barrett esophagus is established, many clinicians recommend endoscopic surveillance programs and biopsies of abnormal tissue to identify dysplastic changes. In an article by Shaheen et al., best practice advice from the Clinical Guidelines Committee of the American College of Physicians is discussed thoroughly. This advice includes upper endoscopy indicated in men and women with heartburn and alarm symptoms, which include dysphagia, bleeding, anemia, weight loss, and recurrent vomiting. Upper endoscopy indicated in men and women with typical GERD symptoms that persist despite a therapeutic trial of 4 to 6 weeks of twice-daily proton pump inhibitor therapy. Severe erosive esophagitis after a 2-month course of proton pump inhibitor therapy to assess healing and rule out Barrett esophagus. History of esophageal stricture who have recurrent symptoms of dysphagia. Recurrent endoscopy after this follow-up examination is not indicated in the absence of Barrett esophagus. Lastly, upper endoscopy may be indicated in men older than 50 years with chronic GERD symptoms, as in this case study, and additional risk factors including nocturnal reflux symptoms, hiatal hernia, elevated body mass index, tobacco use, and intra-abdominal distribution of fat to detect esophageal adenocarcinoma and Barrett esophagus, for surveillance evaluation in men and women with history of a Barrett esophagus. In men and women with Barrett esophagus and no dysplasia, surveillance examinations should occur at intervals no more frequently than 3 to 5 years. More frequent intervals are indicated in patients with Barrett esophagus and dysplasia, as is in this case study. Management and treatment of GERD and Barrett esophagus can begin with lifestyle modifications. This includes weight loss, reduced radiation exposure, diet with fresh fruits and vegetables, and decreased alcohol consumption and tobacco use. Other treatment involves anti-reflux surgery and most commonly the use of proton pump inhibitors. In a research article by Brown et al., patients who had a history of anti-reflux surgery or PPI use without surgery found to progress at significantly lower rates than patients who did not have anti-reflux surgery or were not taking PPIs. This progression is of low-grade dysplasia to high-grade dysplasia and eventually to esophageal adenocarcinoma. Typical treatment for esophageal adenocarcinoma initially involves surgical procedure. This could include esophagectomy or esophagogastrectomy as presented in this case study. In a study discussing the long-term survival of adenocarcinoma of the esophagus after esophagectomy by Orvro, Lai, Larum, Svans, and Vist, median survival time was 20.5 months in 88 patients. By 5 years, survival rates were 31.2% and 27.8% for transthoracic and transhiatal esophagectomy, and by 10 years, survival rates were 21.3% and 16.6%. Median survival time in the absence or presence of lymph node metastases was 74 months. Finally, other treatment methods can include photodynamic therapy, laser ablation, endoscopic mucosectomy, chemotherapy, and radiation therapy. This concludes my presentation on esophagitis and esophageal cancer. Thank you.